Good evening, and thank you for joining us. My name is Kat Cook, and I work at St. Elizabeth Healthcare. Tonight, I'm happy to moderate this webinar on behalf of St. Elizabeth and Mayfield Brain and Spine. Mayfield and St. Elizabeth have been partners for over 25 years, providing neurosurgical and spine care for the Northern Kentucky community. Before we start, let's take a moment to ensure that everyone is ready and familiar with the webinar control panel, which is located on the right side of your screen. First, you can minimize this panel by clicking on the orange arrow button in the upper left-hand corner. You can expand the panel by clicking the same button again. Second, if you have the ability to submit questions using the question pane located on the control panel. If it's not open already, just click that question bar to expand it and you will see where you can type and submit questions to us, which we will answer at the end of the presentation. Finally, this webinar is being recorded and will be posted online for later reference. Now let's get started. We are pleased to have Dr. Tan Nichols join us to discuss the use of robotics in spinal fusion surgery for degenerative spine conditions. Dr. Nichols is a neurosurgeon with Mayfield who practices at St. Elizabeth. Thank you for being here, Dr. Nichols. You may now begin your presentation.
Hello, everyone. As she said, I'm Dr. Tan Nichols, one of the neurosurgeons at Mayfield Brain and Spine, working down here in Northern Kentucky at St. Elizabeth. Hope you're all having a good evening. So the main focus of this talk will be the Mazor X, which is one of the commercially available robotic products for spinal surgery, specifically looking at its use for degenerative conditions in the lumbar spine, which is the main use for the system. First of all, we'll talk a little bit about general back problems, and then we'll move on to some pathology, and then we'll talk a little bit about the robotic platform itself, and then the uses. The key thing to remember here is that this is a tool, and it's not a procedure itself. It's a tool we use to improve the care we can provide to our patients. So back pain, predominantly mechanical in nature, generally due to degenerative joints, what we call arthritis, or a spondylolisthesis, which is when bones are out of alignment. Can also be due to a broken bone, rare time or tumor, and certainly you can have strains and sprains of the muscles and ligaments as well. Neurogenic or pinched nerves are what people think classically as sciatica, so pain running down your leg. That's generally from compression of a nerve root, normally due to either a disc herniation or an arthritic bone spur. To simplify things, we tend to think of back problems as back and leg pain as two separate entities. The leg pain generally being due to a pinched or irritated nerve, the back pain component being due to the actual degenerative process itself. So you could have a back pain from a disc herniation, which is then compressing a nerve, causing the leg pain. Conversely, you could have just back pain if the disc wasn't compressing a nerve but was degenerated, or at times you can have mostly leg pain if you have a fairly mild degeneration but an appropriately placed disc herniation. Looking at the spine, you have flexion on the left and extension on the right. The discs and the facet joints are in purple, and you can see the movements coming up in the next slide. A normal spine, a degenerated spine, as you see the discs collapse in height, and towards the right side of the picture, you have the degeneration of the facet joints that collapses around those nerves and causes pain. Normally, as people extend, they will narrow down the areas around their nerves, causing more pain. For most folks, standing causes extension automatically, so most folks have more pain when they're standing. Generally speaking, people do better when they're seated, because that causes the spine to achieve a somewhat flexed posture, which opens up this area. The spondylolisthesis we talked about earlier is when part of your spine has slipped forward on the lower remainder of your spine, and that can cause the pinched nerves, as you see with the yellow track running down behind the spine, those are the nerves coming down behind the spine that will be kinked and can cause radiculopathy down one or either leg. On what's called an axial view, so looking at the spine from the top down, your belly button would be towards the bottom. You have a fairly normal picture there. You have a herniated disc here, so I tell folks the disc is like a jelly donut. You've got a firm outer donut, and then you have jelly in the inside. And the jelly needs to stay on the inside. When it squirts out through a hole in your donut, it pinches onto things and causes pain, both from chemical irritation of the nerve as well as from direct physical compression. Unfortunately, most disc herniations do tend to occur in the back part of the disc, which is up against the nerve roots. Spinal stenosis is a more degenerative process. As you can see in this picture, that central area is now what we call a trifoil shape, so more of a triangle rather than a circle. And that's due to all the arthritic degeneration of the joints. And that's what can cause people a lot of degenerative problems. We tend to call this spinal arthritis. People can also develop degenerative scoliosis. In a nutshell, your head is supposed to be evenly balanced over your hips. So when you're out of alignment, either to the right or the left, or to forward or back, that can degenerate, cause pain. Classically, the most common one would be a kyphotic posture, which a lot of us achieve as we become older, where our head starts to fall forward on our spine. In general, treatment options for back problems start with less invasive things like physical therapy, which can be quite helpful. In that realm can also be chiropractic care, yoga, home exercise therapy, things of that nature. Look at analgesics for pain relief. Traditionally, we're looking at things like acetaminophen, Tylenol, tramadol, occasionally for short usage, more significant narcotics, although the benefit for narcotics in long-term spine care is marginal. Non-steroidal anti-inflammatories, which are going to be your aspirin, ibuprofen, naproxen, Daypro, things of that nature. Various muscle relaxants, which can help ease spasms in the back that can be caused by some of this degeneration. And then certainly there are steroids. Lots of folks have tried Medrol dose packs in the past for various conditions, and then we can also apply those to a more specific area with either epidural or joint injections. The goal there is to deliver a high dose concentration of medication to a specific area and limit the spread elsewhere. Depending on the condition you look at, about 80% of folks can avoid surgery with these conditions and treatments. And then, of course, there's surgery. Now, not always is surgery the last option. Sometimes it may be the first option if there's something like a fracture or a tumor. Sometimes it's not an option at all. But for most people, especially degenerative processes, we'll try a lot of or all of these things first. So a little bit about surgeries in general. On the left, you have the conventional open surgery, large incision, a lot of muscle dissection, good visualization of the structures. This is how we did things back in the day. Needed to see what we were working with. People were in the hospital for a fairly long time, a lot of recovery times. Moving on to more minimally invasive surgeries, which aren't always necessarily smaller. The key is less disruptive. So generally the incisions are smaller, but the key there is that there's less disruption of the structures. So less blood loss, shorter hospital stays, less time to recuperate. It's a faster recovery surgery because you're doing less disruption. Ultimately, oftentimes the surgeries are very similar once you get down to it, but it's the getting there that's the key. General types of lumbar surgery, you've got your simple discectomies, you have lumbar decompressions, and then you have the spinal fusions that we'll talk about today, which can be for things like advanced spondylosis, spondylolisthesis, scoliosis, which is we talked about earlier with when you're out of alignment, and then certainly things like fracture stabilization. You see in this picture, these can be pretty extensive operations. I'd say the majority of them are not nearly this extensive, but these kind of surgeries are where the Mazor X certainly shines. Spinal fusions, simply enough, are fusing two bones together. Generally speaking, we put a spacer or a cage in between the bones, think of it like a shim, and then we apply screws across the pedicles into the bone to help hold in place while the bone fuses. That fusion will take several months, and ultimately, with a lack of motion, should be a lack of pain and a decompression from the nerve roots, as you can see in that center picture compared to the picture on the left, where the nerve now has much more room around it. Again, left on the normal picture, a degenerative slip in the middle, and then a spondylolisthesis on the right. So the cage has been placed, it's elevated those discs, it's pulled them back into alignment, and then the screws hold them in place. Same there on the right. Various kinds of spinal fusion, a lot of different ways to skin the cat. Remember, these are all different procedures to try to fix the problem and different tools in the toolbox. So on a lumbar spine, you can come in from the front, you can come from the side, you can come from what we call transforaminal, so sort of back to the side, you can come strictly from the back, and in occasional cases, you can actually come up from the bottom through the sacrum. This just shows some of the pictures, various ways to approach this. On the left upper corner, you have a lateral approach. In the middle, you have what we call an A-lift, which is anterior. And then you have a paramedian posterior approach up in the upper right corner. Sometimes you can use multiple different options, and it comes down to surgeon preference or comfort. Sometimes certain approaches are better for certain patients, either based on their anatomy, their pathology, or other conditions they may have had in the past. So this is a picture of the OR with the Mazor X. Of course, you notice there's no buddy in the OR because, of course, we would gum up their pictures, but this shows in basic sense what it looks like. You have an operating room in the center. You have the robot, which is attached to both the bed and the patient, and then next to that you have the programming monitor and several sensors. The benefit of the Mazor X is precision. So it takes a preoperative CT scan, allows us to then determine where we're going to put these screws, set up the robot, and place the screws. We'll talk about this a little more in detail later. Think of this a little bit like a woodworking jig, so it takes a little bit of time to set up, but once it's running, it's very precise, and especially good for areas that are a little abnormal. So one thing people often ask us is, do we use this for every fusion? And the answer is almost all of them. Partly because you get comfortable with it and it's helpful, and also because, like any tool, you need to be good at using it. So you get good at using it by doing the easy stuff first. So you do the easy stuff, and you get good at it, and then you can use it on the hard things. If you only bring your tools out for the tough cases, then it never becomes easier. This is what we're placing for the majority of the time with the Mazor X. These are percutaneous pedicle screws. So think of these like giant woodworking screws with a hole down the center. So the robot helps us deploy a wire down through the spine. We then place these screws down along the spine. These are what's called polyaxial screws. So the heads, which are these colored round top things in this top, will rotate, which allows us to adjust how we place the rods in. Now, that's replacement right here. Think of this like finding a stud behind your drywall. In the old days, we'd take the drywall out. Works real well. You can see the stud, put the screw in, not a problem. Kind of harden your drywall and requires a lot of extra work. On the left side, you have an accurate placement. This is essentially putting your screw through the drywall right into the stud. Everything went well. In the middle, you have what's called a lateral breach, where the pedicle screw misses part or all the pedicle. So this essentially goes through your drywall and misses your stud. Probably not the end of the world. Go ahead and revise it. And on the right-hand side, you have a medial breach. This is going through the drywall, missing your stud, and hitting that wire that was stapled next to your stud. That can at times cause a problem and certainly needs to be revised. The goal of the Mazor X is to decrease both the lateral breaches as well as the medial breaches. And we have seen that with the robotic pedicle screw placement, there's a significantly lower rate of revision of screws than there was in either the freehand technique, which we used to do, or when we were assisted by a fluoroscopy, which is a real-time X-ray. So now we have a little video of how this works. As I talked earlier, we have the OR bed here. We have the Mazor robot here, which is attached to the frame and the patient. This is planning scanner. We have the imaging eye here. So before surgery, it can be even several days before surgery, we will plan how we place these screws. And this can actually even be done in my office with a cup of coffee in my hand. So it's completely separated from the surgery itself. You plan the appropriate size screws, the appropriate location based on what you need. You then load that to the system. Come to the operating room, put the patient to sleep, lock the robot down, attach the robot to the patient. The Mazor X does its magic when it registers the image into the patient's real life. We then deploy the arm, which is this here, and make a small incision down through that arm. We can then place the various dilators and the drill and ultimately put a wire down through the spine, through the pedicles into the front of the spine. That's the wire that we then place the screws down. So then after they've placed all the wires, you go ahead and place the screws. These are all the implants back here. Then you lock the screws together with rods, close things up, and get out of Dodge. Or for example, lateral surgeries here, frequently used to correct scoliosis. Does a very good job with what's called indirect decompression. So think of this like putting a shim in a door. Helps to elevate the disc space, helps to take pressure off the nerve roots. We come through the side of the patient, through the psoas muscle. So if you're a cow, this is your filet mignon. This is one of the softer muscles in the body. Dilator goes through that, docks directly on the disc space. We then incise that. So it's seen there. And we place a graft across that. And you can see the change in height there, and also the change in alignment. You start to elevate it, straightens it out. Before and after. So you've elevated the disc height, you've restored the alignment. This green area here shows the room where the the room where the nerve root would come out. And so it's enlarged. This is the indirect decompression. Doesn't oftentimes require us to come from the back and open up that. Conventional surgeries would require us to drill off the bone behind this green area to open that area up. There's another picture there. You can see the elevation on the left. You can see the elevation of height and a little bit of the restoration of the overall alignment. Top right corner, those are all the K-wires we talked about. These are what would be placed by the robot. You then put screws over that and put the rods down and lock everything in place. Move off to the screen here. On the left, you have the before. On the right, you have the after. What you're looking for is increasing area here for the nerve roots. So here you have this very small area where all the nerve roots are trying to live. Over here, you have a much larger area. As you stretched this disc space, you've pulled these ligaments taut and you've opened up the area. Another picture there. You see the open, tight areas here, especially on this left side. And then once you put the cage in, which is up front here, quite a sizable cage actually, it will open up this area. This is the indirect decompression. This takes the pressure off the nerve roots, relieves the leg pain. The cage stabilizes the disc space, aims to reduce the back pain. So this is a pretty bad picture. A lot of scoliosis, a lot of curvature. Patient likely has a lot of compressed nerve roots where all this curve is. You can come in multiple cages from the side and then put these screws in with the Mazor X. Doesn't line things up perfectly, but makes this individual a lot straighter than they were. Takes a lot of pressure off and likely resolves a good deal of the pain. Transfemoral lumbar interbody fusions. This is coming from the back side, as we talked about. You come in. This is a direct decompression, so you drill off the bone compressing the nerve root, enter the disc, place a graft, followed by K-wires and screws using the Mazor X. Let's see the angle here. Doesn't disrupt most of the tissue, leaves all that healthy muscle alone. Comes into the disc, scrapes out disc material, preparation for graft placement. Go in, slide a cage in, put the screws in with the Mazor X. You get something like this. Good elevation of your height, good placement of your screws with much smaller incisions. This incision is measuring about an inch. That's pretty small, I'll be honest with you, usually a little bit bigger than that, but certainly much smaller than the 5, 6, 7, 8-inch incisions we used to have when everything was an open instrumentation. When you have to see everything with your own eyes, you need a much bigger opening. Treatment for spondylolisthesis, we talked about, was the kinking. You go in, decompress things, place a graft, place the screws, line the bones back up, take the pressure off the nerves. So remember, this is a tool. It is not a procedure. So no one comes for surgery to have a Mazorex. You come to surgery to have in this case, a lumbar fusion, and the Mazorex gives you options. Spine surgery is a lot like carpentry. You need a big toolkit. At the same time, if you have too many tools, you can get too indecisive. You're best to have a few tools, be very good at using them. But the better tools you have, the better job you can do. The Mazorex is one of those tools. Specifically shines when we have trouble with pedal replacement, which can be due to patient anatomy, the pathology of the patient, other limiting factors, but certainly can be helpful for everyone. It takes a lot of the strain out of placing screws, improves the accuracy, hopefully should decrease the length of stay, postoperative pain by making these incisions smaller, less disruptive. As I said, remember, it's not all about the length of the incision. As I had an old attending tell me, incisions don't heal end to end, they heal side to side. That being said, the less tissue you can disrupt, the better people do, which allows us to offer surgeries to folks who otherwise maybe couldn't due to the size of surgery they would have needed. So sometimes there are cases that in the olden times, before we did this, people wouldn't have been a candidate because they wouldn't have been able to tolerate the kind of surgery they need, or that surgery wouldn't have been available. This has opened up that opportunity for more patients.
I'd like to thank everyone again for joining us tonight, and have a great rest of the week.